From the patient point of view, when you develop resistance on a targeted therapy, what should they be asking their doctors? What are the important things that the patient should be aware of when their cancer starts to progress? Can you offer any pieces of advice when a patient reaches this point in their journey?
I can start us off. I think some of the key questions to ask are, first of all, where is the cancer progression happening? So we really care about the location and also the pattern of progression. Dr. Iyengar is touching upon whether the number of sites that are changing versus diffusely multiple sites throughout the body greatly impacts how we think about a potential role for local therapy like radiation or ablation or sometimes even surgery versus switching the targeted therapy an option. So that's the first important question is where is the progression occurring and what's the pattern of progression? And secondly, if we're at a point where we are having to switch the actual medication, then what are the options and how will we decide which one is most suitable for my specific cancer? Really trying to personalize the subsequent therapy as much as possible. And there, it can be helpful to consider repeat biopsy, although there can be variabilities in access and insurance coverage there as well. Then doctor decide what's your practice and what do you discuss kind of in terms of broad strokes when someone is progressing on targeted therapy?
Sure. Yeah. I think first and foremost, too, in addition to kind of whether this is a limited progression or a more advanced progression, is also then discussing biopsy because we know that the sometimes the way that the cancer can kind of outsmart the treatment might be in a way that we have another therapy that's available in an off-label scenario. I think we all have seen this with MET alterations or other fusions where we might be able to add an approved targeted treatment to our arsenal to extend the benefit. Also, we know that the cancer can sometimes look different. So if it's an adenocarcinoma, it might transform into a more aggressive small cell lung cancer. And so I think biopsy is super important there and is important in informing the treatment selection and whether there's something approved. Do we add in chemo or do we look for a clinical trial option?
Yeah, I completely agree with everything that's been said, including the fact I think it's most important to identify whether this is sort of what we call oligoprogression or progression at a limited number of metastatic sites, where we can collaborate with our radiation oncologists or surgical colleagues to see whether there is any local therapy that we can offer while continuing the systemic therapy that has hopefully worked, for a period of months to years. But I think when there is systemic progression, as Dr. Rose mentioned, I would agree that, tissue biopsy is important specifically to look at whether the cancer has sort of changed its colors or transformed into a different histology where the treatment paradigm may be different, more focused on chemotherapy if it's small cell lung cancer, for example. And then I think when tissue biopsy is not feasible, I think I'm increasingly incorporating liquid biopsy in this particular instances where I'm trying to plan systemic therapy in second line or subsequent lines, hopefully based on resistance, the mechanism of resistance. Particularly for EGFR and ALK, and probably other, genetic alterations as well. There are newer generation TKIs that are coming up, which may be more effective against, the common resistance mechanisms. For example, with osimertinib, the C797S, there are other newer next generation, fourth generation TKIs that are currently in clinical trials, which may be more effective in those cases. So again, very important if we can, again, from a biomarker testing standpoint, even in the relapsed, setting, again, for identification of the actual resistance mechanism, as well as enrollment in clinical trials to really target. I think of this as like precision oncology 2.0, like sort of doing it all over again, to make sure that we are really targeting the cancer where it's being resistant to the current treatments.
One other thing I will add is we also look at the pace of the cancer changing. So we ask, is the progression causing symptoms or is it very kind of slow, what we call indolent some of the lung nodules may be growing by 1 or 2 millimeters each scan, and it's really not causing any symptoms. In those scenarios, it's changing therapy right away. If you're having a great quality of life, no side effects from the medication, and it's by and large doing a really good job, the medication is by and large doing a good job controlling the cancer, then sometimes the doctor may recommend continuing to watch for now and seeing what the next scan shows before we rush to doing a biopsy or changing the medication. So you may hear about that approach as well from the doctors.